episode of Conversations with Keith and Courtney. I'm here with Courtney Scales, and today we're going to have a podcast talking about rebreathing systems. So basically, we're going to be talking about circle systems. In talking about circle systems, we're going to look at the different circles that are available there on the market, the common ones, how they behave, how they vary in their behavior, how you use them, how you use them to your best advantage, and give you some insights into their peculiar behaviors, and also look at how we use them in terms of fresh gas flows, how we need to use special requirements or special approach for an animal that's first put on a circle, um, in terms of getting rid of the nitrogen in the system. Going to cover those aspects. Going to look at how circles can really benefit you in terms of reducing gas flow. But when do you reduce gas flow? How much do you reduce it to? Going to cover kind of all those aspects. So just to make a start, just going to say hi to Courtney.
Hello. I'm
Hi.
really excited about this podcast. I think there's a lot of misconceptions, misunderstanding, and fear around the use of circles. And I think we're going to debunk quite a lot of myths, I reckon, about circle systems. So every time I talk to you about circle systems, when it's just you and I, and we don't have, we haven't hit the record button, I always learn something new, and I'm thinking, oh wow, I think everyone needs to know that, because it really will affect every person in practice and how their patient is attached. So no, I'm really looking forward to this podcast.
Yeah, I think what part of the problem is it's almost a black box, isn't it? You just stick it on to your fresh gas outlet, you put the tubes on the end, and it becomes a circle. And I think no one really has to think about, oh, so where's the bag? Is it on the inspiratory side or the expiratory side? When the animal breathes out, does it breathe out into the bag? Does it breathe out through the soda into the bag? Where does the fresh gas come in? Does that come in near the inspiratory port, near the expiratory port? Does it come in on the other side of the inspiratory port, on the patient side? All these things make a huge difference to the performance of it. But I think we tend, and I'm just as guilty as the rest in practice, would have tended to approach it as a black box. There's a circle. It's going to behave in a manner that means that anesthetic gases and breathing gases are circulated, and so CO2 is scrubbed. And that's all I need to know. But I think if you want to be able to use this little kit to the best advantage, it's really helpful and useful to know the intricacies of how a circle works. So there are a number out there, but to be fair, there aren't that many out there. So we'll talk about the semi-disposables. The semi-disposables, we all tend to call them hamster wheels because of what they look like. They're see-through plastic. They're refillable with a soda lime, so you can actually put fresh soda lime in. So we'd call those the hamster wheels, if you like. Then we've got the more sort of permanent devices, like the Cycloflow from Burtons, or like the Humphrey ADE as another common circle. And there may well be lots of others that I'm unaware of in terms of brand names. But so maybe just taking some of those three as an example, we can start to break down how they differ. So one of the things to consider on a circle is, and this is one of the questions: how small an animal can you put on a circle? Well, I think if you look at the traditional literature, you're going to be looking at something around 10 kilos in the literature. They're going to say, well, circles 10 kilos and above. But I think you need to just step back a second and say, well, why 10 kilos? Well, what is it about a 10-kilo animal that is different from a 5-kilo animal? That means that a 5-kilo animal cannot, use a circle safely. And I think when you start looking at it, you'll realize that actually there are reasons why a 5-kilogram animal can be put on a circle. But we just want to look into that because it does vary, obviously, with the makeup of the circuit. So let's take a traditional, a generic circle system. So we're going to have fresh gas coming in at some point, and that's going to come into the canister, typically behind the valves. When I say behind the valves, it's in a container, and then you have to go through the inspiratory valve to go down to the patient limb, and the expiratory limb comes back, and the gas goes through that expiratory valve into that sort of container area where the soda lime sits. And typically, off of that area is where the bag sits. So you've got a rebreathing bag, and the way that it works, obviously, is that as the animal breathes in, it pulls in gas that's bin through, or it pulls it through the soda line, down the inspiratory limb, through that one-way valve on the inspiratory limb. Animal breathes out. That inspiratory valve is now closed, and it can only go back out through the expiratory limb. So we've got that circular flow of gas that's dictated purely by the one-way valve. So the one-way valves are very important, and yet there are normally two types. There's vertical type and there's horizontal type. The vertical type tend to be rubberized, and they flap back into position because they're rubberized. The horizontal type tend to be solid discs that just raise and flop back under gravity. So they behave differently. The semi-disposables tend to be the rubberized type, and the permanent systems tend to have the horizontal type. And the horizontal type generally give you better closing than the vertical flap types. So if you think about putting something very small on a circle system, if we get small enough so the breath is really tiny and only a few mils, then you can imagine that if the valve doesn't close properly, then effectively we've actually got a system that's where we can have two-way passage of gas in that system, because there's just a tiny leak through those valves, but that leak is enough to be significant to a tiny animal. So there are some size limitations based on the valves. And as I said, the horizontal valves will make that much more difficult for them to leak. So they tend to be better, even though they're physically bigger, probably going to be better for the smaller patient. But let's just think about what everybody worries about. I'll put a small animal on a circle. What about the extra work of breathing? Well, okay, what is work of breathing and how does it apply? First thing you have to realize, the work of breathing only applies to inspiration, because when the animal breathes in, that's an active process, and that is work. You have to work those muscles, work the diaphragm, work the intercostals to increase the size of the thorax. That is work of breathing. When the animal breathes out, it's a passive event, and it purely just takes all that stored energy that it created in inspiring, and just lets that energy and elasticity recoil so that the animal breathes out passively. So if there's any work to be overcome, it would be better that it be overcome in the expiration period, and the inspiration period made as easy as possible, because that's where you're working. So what we really want is a circle system where the bag is right next to the inspiratory valve. So when the animal goes to take a breath, it takes a breath, it pulls gas through that valve, but it takes it straight from the bag. It doesn't have to pull it through the reservoir or the amount of soda line that's in there. It just pulls it from the bag. So it's really, really easy. So worker breathing is pretty minimal. So then you say, okay, well, that means that when the animal breathes out, it has to push it through the soda line all the way through and back into the bag again. And yes, it does, but it doesn't matter, because that's the passive part of breathing. The animal breathes out passively, and the only influence that the extra resistance will make is it will slightly elongate the expiratory time. And that doesn't matter. So your cat inspiratory time may go from 0.8 seconds to 0.9, have very, very, very little clinical effect. But by having the bag on the inspiratory side, it's going to make a huge difference to the work that the animal has to extend to pull that gas in. So take a look at the circle that you're using, look at it and see where that bag is. Is it on the inspiratory side or is it on the expiratory side? In other words, when the animal breathes out, does it have to push through the soda line first to get to the bag? And when it breathes in, can it just take it straight from the bag? And the ones that take it straight from the bag are going to be much easier for an animal. So, and by inference, it means we can put a small animal on that. So that's one thing we need to look at. The other thing we need to look at is, where does the fresh gas supply come in? Because it can be introduced in all number of places. Now, there's only really two incarnations that make a difference. One is it comes in on the canister side of the valves, or it comes in on one of the patient side of the valves. Now, just to talk specifics, the Burtons cycle flow that's been around for years brings the fresh gas flow into the inspiratory limb in front of the inspiratory valve. In other words, you have the soda line, you have gas coming up through the inspiratory valve, and then that's where it meets the fresh gas coming in. What that means is that there's always fresh gas coming in front of that valve. It can't go back through it because it's the wrong way round. It can't flow backwards. So in the cycle flow, the gas is always being pushed around the circle circuit, which is a benefit in the sense that it makes continual recycling of gas in the patient circuit. But if we look at one of the semi-disposables, we will find that they nearly always have fresh gas coming into the canister part, into the soda line part, and that's on the back end of both valves. So if you put a lot of gas into one of those, then a high gas flow rate, because there's no difference in pressure against either of those valves, there'll be no flow down to the Y piece. Now, I know this is something that's probably surprising to a lot of listeners, because you think you can put your circle on, turn the fresh gas flow up, and you're going to create flow through the circle. But I want to be really clear, be very careful, because if you haven't got a fresh gas flow introduced into the patient circuit on the patient side of one of those valves, it's just not going to flow around it. To put this into context, done some quick little tests before this talk today, and I set up a semi-disposable. I put 10 litres of fresh gas flow into that circle circuit and measured the flow in the actual patient circuit. And I don't know, Courtney, if you have any guess about what sort of value I might have seen.
Oh gosh, okay. As someone who used to kind of try and pre-oxygenate their patients with circle systems, I would have thought if you put 10 litres in, we would get up to 10 litres going past our patient end. But I'm feeling like this is a little bit of a trick question now.
Well, not a trick question, but yeah, I think you'll be surprised that there's less than 0.1, 0.2 litres of gas going around the circuit. In other words, down to the patient Y piece and back up to the circle, to the soda line, because when that gas comes into the area behind those valves, all it can do is fill up that area, fill up the back a little bit, but as soon as it reaches any pressure, it's going to pop out the APL valve and go to waste. And there's nothing to force air down one limb and not back up the other, because the pressure in the chamber is the same for both sides of that tubing. So there's no differential to create a flow. So this is kind of has clinical importance, and it probably means that you can't use them maybe in the way that you thought you could.
And I think that's probably the big shocking thing for some of us that will routinely try and pre-oxygenate our patients with circles. If we don't know what kind of circle system we have, then we just don't know if we're actually getting flow down to a patient. But it did just make me think then when you said that, when you have the fresh gas flow coming in behind the valve, so within the canister side, not the patient side of things, and you said both sides of the chamber, like the expiratory and inspiratory part of that soda line chamber, there's no pressure difference. So really what makes the pressure difference then is the patient taking a breath.
Absolutely, yes. Yeah. So you could say, if you put a mask on that Y piece and put it on a patient's face, and they made some efforts and created negative pressure, they would start to inspire some of that fresh gas. Absolutely. But if you just have the open end near their nose, like a rabbit that is waiting to wake up. I know that's a circle you probably wouldn't use on a rabbit, but maybe a larger dog, and you had that thing right near its nose to create a little bit of flow by. It will create absolutely no flow by, because unless the patient is connected to it and sucking gas down that tube, tiny amount, as I say, 10 litres a minute into a semi-disposable and 0.1 litres a minute going around the circuit, if that. So you've got to be really clear about where that fresh gas comes in. And that's, as I say, in contrast to the cycle flow, where fresh gas comes in front of the inspiratory valve. And if you were to put one of those in front of a patient, then there would be up to 10 litres of gas coming out of that Y piece itself. So yeah, needs to be very aware of how that system is set up. So that's hopefully dispelled some myths about how to pre-oxygenate with a circle. If you want to pre-oxygenate with a circle, then you can do it, but you have to close off the APL valve, because by closing the APL valve, what will happen then is you will pressurize the cylinder. The pressure on the expiratory valve will be the same as this pressure on the inspiratory valve, but the inspiratory valve can now give. When it builds up pressure, it'll give, and it'll force flow down that inspiratory limb to the patient and out to the room. Nothing will ever come back at the expiratory limb, but you're just forcing it round to the patient, whereas before it just went out the APL. Okay, so if you want to pre-oxygenate with a circle and it's this type, close the APL valve, and then your flow will be directed down to the patient, and you can do your flow by or your pass by pre-oxygenation. But if you want to do it with a mask, you leave APL valve open and use it like a normal circle. So just need to be aware, and the easy thing to do is, if you want to test your circle, connect it up, turn the flow rate up to 4 or 5 litres a minute, put your face near the Y piece and see if you can feel any gas coming out. If you can't, close the APL valve, and then you should feel lots of gas coming out. And obviously you just have to remember to open the APL valve before you connect your patient later. So yeah, that's a little bit of caution there. You have to be very aware that you've actually closed it before you put your patient on it next time. Okay, so I think, yeah, pre-oxygenation is different depending on the types. The resistance is different depending on the types. So it's becomes important to begin to understand what type you've got, and then that will start to indicate what you can do with it. And by that I mean, it's something we'll maybe should cover in more detail in another talk, but it is quite possible to put sub 10 kilo animals, substantially sub 10 kilo animals, onto a circle system. But you really want the animal to be breathing out into the soda line before it goes to the bag, and you want them to be breathing in from that bag straight into the inspiratory limb. So make sure you've got the right one. Okay, so circles are very different from non-rebreathing circuits that we talked about before, because we do have this circulation of gases. Now, that has some implications, particularly when we start putting an animal on a circle system, because they will have come from an environment of 21% oxygen, and now we're going to put them into an environment where basically we're running 100% oxygen, or that sort of level, and something has to change. And I think, Courtney, maybe this is one of the processes that you can talk the listeners through, the denitrogenation phase of a circle system.
Yeah, of course. I think this is quite a common question that I actually get asked a bit, and it's to do with fresh gas flows within a circle. And it's not even the maintenance flow, because once again, our favourite saying that we've kind of developed over the last podcast and this one here, being 2 and 2 just won't do, in terms of a 2 litre per minute fresh gas flow. The maintenance side of a circle system fresh gas flow is definitely something we'll touch on in a little bit. But just for now, I think we need to think about the volume of this system that we have. So when we use when we use a non-rebreathing system, there's very little tubing. We have a nice high fresh gas flow rate, little volume of tubing, because there's no big canister. And that fresh gas usually gets straight down to our patient within seconds as soon as we turn on our flow meter. But when we have a circle system, we've got the canisters that we need to get all of the room air out of. So that's where that word denitrogenization comes from. So our room air right now that we're breathing in, so we've got 21% oxygen in it, and then most of the gas remaining is going to be nitrogen. Nitrogen's great, it's fine, we need it, helps hold our alveoli open, but in our circle system, we need to push all of that out and then replace it with 100% oxygen, or as high of a concentration as we're able to deliver with, a concentrator or whatever we have. So we have a nice high fresh gas flow initially, and that's going to go through our circle system. That could be up to 2 or so litres, 1 to 2 litres by the time you've got soda lime or CO2 absorber granules in your canister. We've got quite a lot of volume in our tubing as well with the circle system. And also we have about a 2 or so litre bag. I mean, reservoir bags are another thing to talk about. But if we think about the size of the canister, the size of the tubing, and then the size of the reservoir bag, we've easily got the system of 6 or 7 litres that we need to fill up now with this high percent of oxygen and also our volatile agent for our patients. So if we were to put our circle system onto like 2 litres per minute, for example, It is going to take quite a few minutes to displace all of that room air, all of that nitrogen out of the system, and then fill it up with 100%. So if we can have a nice high fresh gas flow rate initially, usually it's kind of estimated at 100 mils per kilogram per minute. We just need to push all of that nitrogen out, saturate the system with volatile agent, and usually we're going to do that for about 10 or 15 minutes.
Absolutely. And just one point I was going to make, and sorry to interrupt it in a sense, but remember, we were just talking about the flow through the circle is dominated by the patient's breath.
So they're going to have to breathe.
Absolutely. If the patient doesn't breathe, it will not denitrogenate. Yeah.
Yep.
So
absolutely.
That obviously needs to be taken into account. And so what you really want to know is, what are the oxygen levels in the system? So, it would be really, if you're lucky, you've got a multi-parameter that measures oxygen levels, and that'll tell you nicely. But there are some, cheaper alternatives. You can buy a little oxygen analyzer, sit it on the outlet or the inspiratory limb of the circle, and that could tell you the oxygen level, and then you wouldn't have to go into this guesswork. So
yes, exactly, because we kind of guess now, don't we? We kind of go, 10 to 15 minutes, that's probably enough for the patient to have taken some breaths to create that pressure change with our high fresh gas flow rate to push all of the room air out. But a nice little kind of analyzer there. If you could imagine, I can just imagine this oxygen analyzer sitting there showing 21%. We turn on a vaporizer, and then over the next few minutes, watching it get higher and higher and higher and higher. And then once it is kind of up to that 95, 100%, then we know we've denitrogenized the whole system, and we can go down to our maintenance flow rate if the patient's anesthetic depth is appropriate.
That's right. So, I mean, just to make it clear, why we want to, denitrogenize them is basically we just want to get the oxygen levels up. And if you don't get the oxygen levels up, we're not going to get to the oxygen delivery levels that we want for anesthesia, because
or that we think we're giving.
Yeah. So we just have this period of equilibration, get rid of the nitrogen, and it gets replaced with oxygen, and that just takes time because of the fact that the animal has it in his lungs and has to take a number of breaths in and out to start clearing it and replacing it with oxygen.
Yeah. And I think, once again, like, there's so many confusions around anesthesia in general, and if we have a calculation for it, it makes us feel a little bit better. So the textbooks will say to run this fresh gas flow rate at 100 mils per kg per minute, but in the real terms, I don't often do math. I just kind of whack up the oxygen flow for a bit, and then by the time we've done the surgical prep, we've clipped him, we've prepped the patient, we're about to move them, that's usually enough time for that circle system to have hopefully equilibrated and then gone down.
Yeah, and I think when you say in general terms you whack up the flow, I think what we need to bear in mind is that when we whack up the flow on a non-rebreathing, we're talking 6, 8, 10 liters a minute. When we whack up the flow on a rebreathing system like a circle, we're probably talking more down at 4, 5.
It's not way high.
We don't need 10 liters of flow in a circle system to help our denitrogenation. So it's a kind of different approach. Same, we do need higher flows initially, but they're nothing like the excessive flows you would see in a non-rebreathing system. So, sure, sorry, I interrupted you. So we've gone through that denitrogenation zone or period, and then we need to think about our maintenance.
Yeah, and our maintenance flow, I think, is the one that makes people a little bit nervous, because it is low flow. Like, we can put lower flows than, once again, comparing it to the non-rebreathing systems like you just did before, it is going to be lower flow than the non-rebreathing systems. And we have to remember why our non-rebreathing systems have this high fresh gas flow rate. It's so that there's constantly new fresh gases being supplied to the patient. And then also, depending on the system, enough of a fresh gas flow that is able to push out that expiratory breath and push out that CO2, because we don't have any way to absorb it otherwise. But we know with our circle systems, we have this canister, we have CO2 absorber. Most commonly, it is going to be soda lime. So we really don't need to be providing such a high fresh gas flow to push out carbon dioxide, because that's what our carbon dioxide absorber's job actually is. So really what we need to replace in our circle system, and which is what makes the flow so much lower, is we just need to replace what the patient actually took from that system. It's not necessarily their tidal volume at all, because there's a lot of dead space gases in there that we're going to get to reuse. It's going to get to go around the circle system, doesn't even have soda lime in it. But it's just their, literally write down their metabolic oxygen demand. And this, depending on what you read, is usually about 2 to 7 mils per kilogram per minute, or we kind of like round figures in anesthesia maths because it makes us a bit more comfortable. So 10 mils per kilogram per minute. So let's take a 10 kilogram Jack Russell that has a metabolic oxygen demand of 10 mils per kg per minute. So therefore, it is using 100 mils of oxygen in that minute, right down at the cellular level that we need to be replacing for that patient. We can't really, if it's 100 mils, run our flow meter as low as 0.1 litres per minute, because our vaporizer, we need to factor in the accuracy of our vaporizers. And they often need, depending on what kind of make or what model you've got, they do need a specific flow to go through them in order for them to deliver an accurate amount of volatile agent. So typically, it varies for a lot of different vaporizers. So I'd hate to say it's going to be this or that, depending on what you've got. But around half a litre per minute it's going to help most vaporizers function well and deliver an accurate concentration of gas, what's on your, closer to what's on your dial there. So once I've kind of pushed all of that room air out, I've got rid of all of the nitrogen with my really high pressure gas flow rate that I've put up to about 3 or 4 litres per minute for 10 to 15 minutes if I don't have an oxygen analyzer, I usually just reduce that flow straight down to about half a litre to 1 litre per minute, because I know I don't need to flush out CO2. I've got CO2 in there, absorb it, and they're doing its job. So I just really need to replace what the patient's needed. And in fact, based on that calculation of 10 mils per kg per minute, I'm massively exceeding it, but I don't really have a choice because the vaporizer needs it. And also we've got side stream capnography as well, and they take off a sample rate of between 50 to 200 mils per minute, depending on what you've got, what type of multiparameter you have. So we have to replace that as well. So I find that about half a litre to 1 litre per minute for maintenance phase in a nice stable anesthetic where you don't have to change the concentration in that 4, 5, 6 litre system quickly is a perfect maintenance flow. And that's what makes it quite economical to use. And we don't have so much atmospheric pollution.
Absolutely. So one of the things I just wanted to sort of point out, maybe in a way to help understand the circle system and this idea about once you've got rid of the nitrogen, you can reduce the fresh gas flow rate, and how low can you go? Well, we have to think about the circle system, whether we're running it as a closed system or a semi-closed or an open system. Okay, and that very much depends on the flow rate that you're introducing and how you use the valve. Now, I think it's quite a striking demonstration to actually have a patient on a circle system and turn the oxygen flow rate right off. Okay,
I've done that sometimes for a bit of
and
a
have
look.
an oxygen analyzer. Have an oxygen analyzer in there somewhere, either part of the side stream system or one of these just inline analyzers, and just look at what happens, because it actually takes quite a while. You've got a few liters in there of 100% oxygen, and we said that the demand is 10 kilo dog, 100 mils per minute, so that's 0.1. So actually it's going to take 10 minutes before you lose a liter of oxygen. So in a reasonable sized dog, you can turn the oxygen right off. The agent will continue to circulate at the current level. So as long as your patient's stable, it'll breathe in, breathe out, and it'll just come back in again. So it'll stay at a stable level. And then it takes a significant amount of time to watch that oxygen go from 97, 96, 95, and we're not in any danger until we get, maybe down to sort of 40 or 30. And I wouldn't suggest you ever do this, as a sort of way to run a clinical anesthetic, but it does show you just how little oxygen is being used by an animal using its metabolic demand. So that it gives you, I think, just doing that demonstration gives people confidence to say, well, actually, 10 kilo dog, I don't need to have it on 2 liters. And in fact, if you have it on 2 liters, what is effectively happening is that the gas is coming into that chamber, it's filling it up, and most of it is going to go straight out of that APL valve. Okay, so in those circumstances, all you're really doing is wasting 1.5 liters of gas per minute, and because of that, you're wasting 1.5 liters through your vaporizer, and you're losing agent at that rate as well. So that just wanted to mention, if you turn one off, it's not awful. You turn a non-rebreathing system off, the animal gets no gas at all. But you turn a rebreathing circle system off, and the animal has plenty of time to carry on breathing. So as a very practical example, if your oxygen cylinder runs out and it's on a circle, fine, turn the oxygen off and take your time changing the oxygen over, because it's not going to come to any harm. So yeah, just wanted to jump in and sort of say that there. And I guess from that we should, well, I'll let you carry on talking about your flow rate. Sorry, I interrupted you on the flow rate.
Oh no, that's fine. I find that part like quite exciting to think you actually can turn off your oxygen flow and everything's okay. And sometimes I, when I was in the teaching hospital, and I would definitely gauge the students' confidence and adrenaline level beforehand. But I would say, well, let's just turn off the oxygen. And, we've got no more flow through our vaporizer anymore. So let's turn off the oxygen and the vaporizer. We were fortunate enough to have agent monitoring, and these patients are on a circle system, and I would just, I'd probably only get to about 90 seconds before I could see the student visibly sweat. I think, oh my gosh, turn it on. But it really just comes down to understanding how, like, the volume of that system and how it actually works, and that we only really need that high flow to push out CO2 in a non-rebreathing system. But for our circle, we've got something doing that. We can have that really low flow, and that whole, whatever liter system you've got based on your reservoir bag, the soda lime canister and the tubing, you have you've got minutes and minutes and minutes of reservoir in there of anesthetic gases. So I think from a clinical practicality point of view, like I said, for lack of a better words, I used to just whack up the oxygen flow to about 3 or 4 liters per minute for 10, 15 minutes. And then I would just reduce straight down to 0.5 to 1 liter per minute. And I think what we have to consider then, though, is that over time, what is on that vaporizer that we deliver to our patient is not truly what our patient's going to be receiving, because they are like this big sponge. And please do interrupt me, Keith, as I go on about this, because this is how my brain processes it, is that we've got our vaporizer on 2%, we've got our fresh gas flow going in, and even if we have that really low fresh gas flow of, say, 0.5 liter per minute at 2, and our vaporizer on at 2%, and we have a system that's 4 liters in volume, and it's only getting 0.5 liter per minute, so it's going to take 8 minutes to get that volume every single time, perhaps minimum, every time we change that vaporizer ever so slightly to change that patient's anesthetic depth. It's going to take a long, long time if we have running such a low flow to change the concentration in the system for the patient. Because every time they take that breath in and they take in the oxygen and the anesthetic gas, that's still that sponge that needs to kind of equilibrate. So they keep that little bit of, tiny, tiny little bits of gas. And then when they exhale, they might inhale 1.7% and only exhale 1.2%. And I think over time, we need to remember that we're going to get further and further of a dilution with the circle system. So perhaps what you see on your vaporizer isn't always what you're delivering to your patient. It's often you're delivering quite a lot less within that circle system.
Yeah, absolutely. And I think this brings us on to another point, really. When talking about volumes, and we're really talking about things like what we talk about time constants. So because of the volume involved, when you start off and you put 2% on your vaporizer, 2% goes into the inspiratory side. The animal breathes in 2%, breathes out 0.4% or something, and that 0.4% then goes into up the expiratory limb, and then goes into the volume that was in the canister, which is at 21%. So that agent level has now gone into a bigger volume, so the 0.4 becomes 0.1 or less, and it takes a long time for that to for those levels to change. Now there are some mathematical figures you can use, but it basically takes 5 time constants before you get to anywhere near. I think 5 time constants takes you to 96%. So if the time constant is what we calculate from the volume divided by the flow rate. So the volume of the system, let's keep things really simple. Let's say the volume of the system is 10 liters. That's big, but let's just say 10 liters for numbers. And our flow rate is 1 liter per minute. Then one time constant is 10 liters. And that takes, that's going to, 1 liter a minute, that's going to take 10 minutes. Yeah. If you want to make a change in that system, you need 5 time constants. It's going to take 50 minutes at 1 liters a minute to change a 10 liter system. Now our systems are more like 2 liters, and we're probably flowing when we're denitrogenizing at 2 or 3 liters a minute. So we got a single time constant of about a minute, but we need 5 time constants to get to where we need to be. So that's going to take 5 minutes or so, which is why you have to allow all that time for that change. And it's the very same process when you want to change agent concentration up or down. You've got that volume that you have to change with introducing the new level of concentration. It has to equilibrate in the whole system. It's going to take a lot longer time, which is typically why you'll see people squeezing bags to empty them. Okay.
Yeah, and I just do that just to reduce that volume of that system by, if I've got a 2-liter bag and I just quickly empty it. Well, but usually if I'm trying to change the concentration in my breathing system, either I'm trying to increase anesthetic depth or decrease it, I change the vaporizer setting and the fresh gas flow, and then I dump the bag. And it's not a positive pressure breath to the patient. It's a nice, slow, so it's going to hopefully go path of least resistance. And then by doing that, I feel like I've removed almost a quarter of the volume of the whole system, and hopefully speeding it all up.
Exactly. It's going to speed up the change that you want to occur. That's right.
Yep.
Yeah. And if that doesn't act fast enough, you wait a couple of breaths, you empty the bag again.
Yep.
And repeat the process. So so that volume is important. So people will be aware that changing the vaporizer concentration or position in a circle system is going to lead to a much slower change in response to the patient. Where in a non-rebreathing, it's almost instant, isn't it? You've changed the percentage. That's what the patient gets. So
and so that means then
approaches.
that reservoir bag size is also going to impact the concentration of our breathing system, how quickly we can change things, because it's just this extra volume the bigger we go on our bag.
Absolutely. Yeah. So if you take it to extreme and you put a 10-liter bag on there, that's just going to make your circuit volume huge and take a lot longer. So if your patient is a small 10-kilo or whatever, then put a 1-liter bag on. It's going to act a lot faster or respond a lot faster than a 2-liter bag. Yeah. Okay. So one other thing we need to think about then is the soda lime itself. I think we haven't really discussed the soda lime itself. And people say to me, "Oh, how long should how long should my canister last?" Because soda lime seems to sometimes it be, I work in this practice and they replace the soda lime every day. Work in this practice, they do it every Wednesday. What's happening? I think you have to remember the soda lime only gets exhausted if it actually has CO2 going through it. Now that might sound odd, but if you're running your system at high fresh gas flow rates and your APL valve is almost open all the time, the patient breathing out, and particularly depending on where the APL valve is, but it's often on the expiratory side of the circuit, will just see that gas coming out and go straight out the APL valve because that bag is full because you've got high fresh gas flow rates. The gas comes out and goes straight out. So it doesn't go through the soda lime. And in that sense, you're running a very inefficient system. You're running what's called a very open system. Your soda lime will last for ages. If you were to reduce it to half a liter, like we just suggested, and that APL valve is just lightly loaded, then actually you will actually then encourage gas to go through the soda lime, and soda lime will be used up. So you have a trade-off between, do you pay for agent that's going out the window, or do you pay for extra soda lime? But if someone listening to this says to themselves, "Oh, we hardly ever replace our soda lime," well, I can guarantee that you're not running a circle system in an efficient manner. You're running it in a very open manner with high fresh gas flow rates, and you're not getting the best out of that system. If you're listening to this podcast and you're one of those that are using in a nice low flow system and a nice sort of manner, you'll be changing your soda lime every day or every couple of days, depending on your caseload, but you're going to be frequently changing it. So just looking at how soda lime is being replenished gives you an indication of how well people are using the system as it's intended.
And I guess that there's some people, there is out there in the world, there is a little wee check sheet basically, and it's like a laminated sheet that hangs off the side of your your circle system, and for every 15 or 30 minutes of anesthesia, you check it off. And then it ends up being about 6 or so hours. And then once you've done 6 hours of anesthesia on your circle, time to throw out the soda lime or the CO2 absorber and replace it. And I'm always thinking, oh no, you're probably just wasting so much soda lime because, first of all, like you said, unless you're running it at a really low flow, it's unlikely being used. But also, I think in some canisters, size dependent on the canister, you can get a lot longer than 6 hours out of use. And even looking at color change as well, should we change it based on how the percentage of granules that are expired? Let's bin it then. So I think, for me, the best way of knowing when to turf out that soda lime is just having a look at my capnograph.
Absolutely, to see whether we've got any rebreathing. So it's failing to be scrubbed, so we'll start to see an inspiratory fraction.
Yep. Otherwise, no, I'm not a big fan of the little wee cross-off sheets that say, yep, throw it out after 6 hours or 12 hours or 20 hours. There's some out there that say that, because unless you're really using your circle system, like you've said, and you're making that patient exhale and go through that the CO2 absorber, it's probably just going out the scavenge, and that CO2 is never getting a chance to touch a granule anyway. So that's
exactly. So the poor practice is losing out on two counts. They're putting high flow rates into a circle system, so they're using high levels of oxygen flow, and they're using a lot of anesthetic agent, because obviously the higher the flow, the greater the anesthetic agent use, and they're throwing out their soda lime on a periodic basis when it's not being used anyway, because their circle is being run as basically an almost open system.
yeah.
So there's a lot, even on economic terms, to just be gained by looking at your flow rates, reducing them, so that actually when you do throw out an exchange of soda lime, it's actually been used, and at the same time you're using much less oxygen and much less agent. And I think just going from 2 liters a minute to half liter a minute is just that's significant. Over time, that's going to have a huge saving in agent, huge saving in oxygen, and a marginal increase in your soda lime consumption. But it's really worth getting to know your circle system, understanding it, and using it the way it should be, the way it was intended.
And I think another benefit is if there's any way that I can lengthen the time between trying to fill up a soda lime canister, the less frequent I've got to do it, the better, because some of them are a bit of a pain.
Absolutely. Yeah, it's not a simple,
So to
easy
save my
task on
time
some
as
of them.
well, isn't it? Yeah, absolutely.
So I think that that side of things is important to look at as well. So that kind of brings me on to the question about we got on our sort of topic list here of things to talk about, whether that exhaust valve should be open or closed. And during your denitrogenation period, do you want to sort of explain how you control that valve?
I mean, I would personally, as old Courtney, I'd like to hear your opinion. In all honesty, I never used to touch the exhaust valve. I always just used to have it in a pretty open state.
Okay. No, I think that's fine. There are different types of valves. Some are spring-loaded, some aren't. On some of these semi-absorbable systems or disposable systems, they aren't spring-loaded. They're either open or closed. If they're of that type, it's quite difficult because a very little pressure tends to raise them and force them out. So even trying to run a low flow system, you can actually lose gas through the APL valve before you want to. But I think if you're going to run a semi-closed system, then you do need to have a little bit of pressure on that valve. It's a bit like the non-rebreathing system, where we talked about the efficiency of a non-rebreathing system being dictated by that 1 centimeter of pressure. There's a little bit of pressure to rise it. So and you need to have that same sort of approach on a circle system. So you would just lightly turn that during the denitrogenation period, open it. But when you've done that period, then you'd lightly close it. So it just took a little bit of pressure, and you'll see it. The bag will start to inflate, get to a little bit of pressure. It's not going to get big and tense, but it's going to get to show a little bit of inflation, and then you'll hear the valve open, and that's where you want to be. That's exactly where you want to be, because in that situation, when the animal breathes in, it takes gas from the reservoir bag, and then it breathes out. There's been gas added from the fresh gas, so it almost breathes out its whole breath, and then the expiration of loss of gas from the circle is done by the incoming fresh gas, not by the work of the patient. The patient doesn't see that extra load, but the fresh gas coming in is the one that lifts the valve, and it only wants to be a centimetre or so, just to encourage that bag to fill back up again, and then for the valve to open. So that's how I would approach it. But during that denitrogenation period, you just want gas coming in, round, out, and you tend to open the valve and then close it later.
But just a opinion from you, really. If you were going to advise a practice to lower that flow, close that APL valve slightly, just to make sure that you're promoting circular movement of gas within the system, would you advise them to have a manometer on their circle system?
I would always advise them to have a manometer on their circle system. That's probably not going to show very much in terms of when that valve opens, because we want it to open at 1 centimetre or just a very light loading pressure. And the manometer needle will hardly waver then. But coming on to something I think we're going to talk about in another podcast later, it's very easy to perform IPPV with the circle. It's so easy. It's a dream, because in the non-rebreathing circuits you have to consider all the fresh gas flows and where they're going and whether you're actually just pumping CO2 back into the animal. But with a circle, that's not a consideration at all. You simply squeeze the bag, watch the chest inflate, and then let go, and the valves take care of where that gas is going. But you do want a manometer in that circuit to know when you squeeze that bag how much pressure you're applying. So my suggestion would be always have a manometer in circuit.
But it's not going to be used for when you close that exhaust valve. It's more correct for giving those breaths. Perfect.
Yeah, that's right. Yeah. Okay, so we've covered a lot of sort of features of the circle. So I think what might be helpful now, it's kind of sort of getting towards the end of this little discussion, is to present maybe the pros and cons of a circle system, and what does a circle system offer? What features do you want to use that are desirable? And so what are the features that maybe aren't so desirable? So do you want to lead with the pros there, Courtney, and sort of?
Oh, yeah, of course, because I'm always pro circle. So given all the pro benefits, it's going to be easy for me.
Yeah.
I think we really clearly have shown one of the pros being that you can use lower flow rates of oxygen. So that's going to have a cost impact, like a positive impact for your practice, but also it's going to take through less inhalant agent as well, because you have that low flow. Anytime you have your flow meter up at whatever litre per minute, that is going past and through the vaporizer and collecting volatile agent, probably just to go out into the scavenge. So if we can decrease that fresh gas flow rate, we're going to use less inhalant agent. We're going to get the chance to reuse quite a lot of that expiratory breath that has got the isoflurane or the sevoflurane in it. So we're going to save money that way. And I think in our last podcast, we had a look at a normal patient that was on isoflurane, and we were delivering about 1.3, 1.4%. And for a flow rate of 4 litres per minute, we were churning through about 20 mils of isoflurane an hour, whereas once we just even decrease it to 1 litre per minute fresh gas flow rate, we're only getting through like 4 or 5 mils, like a teaspoon. To think that a teaspoon an hour can keep our patient anaesthetized is incredible. So we've got a decreased fresh gas flow rate. We're saving oxygen. We're not putting so much volatile agent out into the atmosphere. We're not wasting it as well, because there's a cost to buy that. And I think one of my favorite things when we start looking at the impact for the patient is that we get to preserve that warm expiratory breath, because it gets to, the way that our airways are built, unfortunately in anesthesia, we get to bypass with an ET tube a lot of the nose and the nasal turbinates. But still, that breath as we breathe it in and then exhale it, it is warm, and therefore it just gets to go back around the circle system and not be so cold and dry and harsh to our airways. But also the reaction of CO2 with water and our CO2 absorbing granules, that is a heat and moisture generating chemical reaction. So we get to reuse our patient's body, that nice warm air that came out of their body, and we get to put that into the system. And then this reaction of soda lime and carbon dioxide and water, that creates heat as well. So we've got this nice warm and humidifying breathing system as well. So we get to keep our, like that nice waving cilia that's in our airway, we get to keep that nice and happy, and it's not going to dry out with this really cold, harsh gas flow constantly coming through. So I think there's benefits for both the patient and also the economic side of things.
Okay, so I mean, I'll summarize on the sort of the cons, if you like, for the circle system, which aren't that great, really. I think one of the ones one has to be aware of is the increased resistance to breathing. I think, as I mentioned right at the beginning, if you buy a circle system or use a circle system that's got the correct arrangement, the increased resistance to breathing is not really a consideration. So it does mean you can take animals, very, very low in weight and still get normal circle function. It's probably going to be some time in the future, but I'm hoping that we're able to do a study on this with some of the circle systems out there and actually come up with some real values now in the future for what sort of animal size we can realistically use on circles. So that's something to look forward to. If it's a con, I'm not sure if it's a con or just a feature. Be aware that the concentration changes slowly with the circle system. You have to be more proactive in changing the agent concentration. They're slightly more complex than a non-rebreathing circuit, and sometimes if you haven't got the right bit in a non-rebreathing circuit, you can pinch something from somewhere else, couple it together, put a 15 into a 22 and back to a 15 again if you have to. But with a circle circuit, you kind of got to use it the way it's presented, and you can't really mess around with that APL valve. And obviously, one of the things that you have to replace the soda lime. You have to keep an eye on those granules, watch for the color change. And I think some of the things that are confusing are that some of these indicators, that are basically pH indicators, will show a change in color, and then as the moisture is drawn out of them over time, so they go purple in the evening after a full day, and then the next morning you come in and they've actually lost that purple tinge. They're not as purple as they were, and even sometimes looking normal, but they are basically exhausted. As soon as you get a bit of moisture in to activate that litmus effect, then you'll see that they're exhausted. So a little bit more management on those than obviously with a non-rebreathing system. But yeah, I'm a big fan of the circle. I think it does need to be understood to use it correctly. But if you do understand that, then it is a very useful tool and a good way of reducing agent and oxygen usage.
No, I
Okay.
definitely agree. It's one of my favorites. So no, I am all on board.
Okay, well, I think here we are, nearly at the end of the hour again, and there's probably lots more we could talk about with circle systems, but just going to wind this one up now. And Courtney, I think, what are we talking about in our next podcast?
And next, so the next podcast, the podcast 3 and 4 in our series 2, will be about ventilation. So actually, I think everyone's going to be really excited because we've just built this foundation knowledge about some of the equipment we can use to ventilate our patients. So we'll talk about how we can ventilate our patients, whether or not you have a ventilator. So if it's manual ventilation or if it is mechanical ventilation, how we can safely deliver those breaths and some of the things we should be considering.
Excellent. I think that'll pull in a lot with this podcast and the previous one about flows and what happens to gases when you squeeze a bag in a non-rebreathing system, and what happens in a circle system. So brilliant things to look forward to. Well, thank you very much again, and I look forward to the next one.
Thanks, Keith. See you later. Thanks
for listening to this week's podcast. Don't forget to follow our podcast to stay up to date with the latest episodes, and feel free to share this with your team. If you have any questions or feedback for us, or simply want to know more about what you've just heard, please feel free to send us an email at clinicalsupport@burtons.uk.com. Thanks for listening, and catch you next time.